Thank you, Chairman. Thank you, Dr. عزت علي for inviting me to give this talk. لأنه الفاتي بانكرياس الكلام عليه قليل والمحاضرة صغيرة، فأنا هحكي شوية حاجات من التاريخ أحسن في الأول شوية. البوكس اوف باندورا، بوكس اوف باندورا زي فكرة بالظبط تفاحة آدم. بوكس اوف باندورا in the Greek history كان آلهة العصر الجريك إبيميثيوس زوجته باندورا ائتمنها على بوكس انها ما تفتحهاش لان البوكس دي فيها اسرار من السماء. هي ما قدرتش الحقيقه تريزيست التمتيشن، وات certain point in time فتحت البوكس، والبوكس دي كانت مليانه ارواح شريره، sickness, evil, death، وانتشرت في العالم كله وعم الفساد بسبب باندورا انها فتحت هذه البوكس. Fatty pancreas, are we opening the box of Pandora? Do we know احنا داخلين على ايه؟ Those are my references. Fatty pancreas is an evolving medical entity specified by parenchymal fat deposition within the pancreatic tissue with an increasing prevalence. This may be due to widespread use of imaging as well as globally increasing prevalence of metabolic syndrome in general. It was first described by Ogilvie, who is the same person who described the Ogilvie syndrome in literature in 1933, and the clinical relevance of fatty pancreas is still not entirely known. However, some studies have linked fatty pancreas to metabolic syndrome, pancreatic exocrine function, diabetes mellitus, cardiovascular disease, fatty liver, and to pancreatic cancer, but still we don't know the relationship in which direction. Is it a cause or is it effect or is it a result? The literature is very limited on the possible causes of factors of fatty pancreas and mainly relies on observational retrospective data, whereas laboratory and clinical interventional well-designed trials are still lacking. Even the nomenclature, لأن هو لسه not established، فتلاقي ناس using the term fatty pancreas، تلاقي ناس تانية using pancreatic steatosis، or even non-alcoholic fatty pancreatic disease على غرار النافلد، وكل واحد طبعا ليه المعنى بتاعه، لكن the general agreement is about fatty pancreas and pancreatic steatosis unless there is inflammation. It is a quite prevalent disease, although data are still lacking. لكن from the Asians we have data, especially in children and young adults, and the prevalence of NAFPD ranges from 16 to 35%. وفي study from China, I think it was the largest study that I found in literature, فيها more than 4,000 patients. Adults found a prevalence of non-alcoholic fatty pancreatic disease of 11% and a higher incidence with age and gender, طبعا men as usual more affected, in adults less than 55 years. A meta-analysis pooling data from 11 studies with more than 12,000 patients برضو yielded a prevalence of about 33%. الحقيقة, although epidemiological data are scarce, but still such high prevalence cannot be ignored, and we have to, day by day we will know what we are approaching. Fatty pancreas, is it just a finding or is it a disease? الباثوجينيسيس two main mechanisms, fatty replacement and fatty infiltration، وطبعا بيجي على استحياء الموضه الديسبيوزز والمايكروبيوتا والرول بتاعها في الباثوجينيسيس. لكن الفاتي replacement is characterized by death of pancreatic acinar cells and their replacement of adipocytes, whereas in fatty infiltration there is no death of the cells, but it is characterized by the accumulation of fat in the pancreas in association with metabolic syndrome and or only obesity. The causes and the risk factors that may lead to fatty pancreas are quite numerous, like metabolic causes, drugs and toxins, infections, local causes, and others like hemochromatosis or just old age and cirrhosis. Notably, the metabolic causes are the most important and most widely investigated causes, like the metabolic syndrome, diabetes, obesity, dyslipidemia, insulin resistance, etc. Diagnosis always, طبعا, as we all know, the most definitive diagnosis in medicine is histology. So histological biopsy is the gold standard for diagnosis, plus of course imaging. الهيستوباثولوجي had the advantage انها قدرت تحط cut off point للامount of fat, the quantitative value, 6.2% or more. This is fatty pancreas. However, the biopsy is inadequate for routine clinical applications طبعا علشان the difficulty of obtaining tissue sample. الالتراساوند هو طبعا الموست widely used وال easy to do بالرغم من الليميتيشنز بتاعته. لو العيان اوبيز، لو العيان عنده جاسز، فالبانكرياس هيبقى شويه مش قادر يحكم عليه. لكن التراساوند هو widely available to detect pancreatic steatosis، وبيقارن دايما الايكوجينيستي of the pancreas to that of the kidney. وعندنا grading systems للالتراساوند starting from grade 0 to grade 3. Grade 0 where pancreas and renal echogenicity are similar, and then the echogenicity and hyperechogenicity starts to increase by grade until it reaches that the pancreas echogenicity is similar to or even higher than the retroperitoneal fat, which is the most echogenic. CT برضو focal pancreatic steatosis can be present as a hypoattenuating mass lesion on CT. This is worthy of note ان الفاتي pancreas او الفات when deposit in the pancreas مش لازم يبقى homogeneous. ده ممكن يبقى focal في الهيد، في النك، في التيل، في البودي. So ده بيلخبط شويه. الCT والMRI هنا they come in handy. The disadvantage of a CT طبعا اللي هو exposure to radiation والhigh costs and can miss focal fatty replacement of the pancreas. The fatty pancreas can be classified by CT برضو ب classification system like that of the ultrasound. The EUS, the king of diagnosis in GI and liver disease or hepatopancreatic biliary disease. Diagnostic accuracy of pancreatic steatosis by EUS is superior to CT and MRI together. EUS is the most sensitive investigation for pancreas screening, but pancreatic biopsy is best to measure pancreatic fat concentration. And طبعا الناس اللي يشتغلوا EUS يقولوا لنا انه this can sometimes be very difficult obtaining a biopsy from the right place. EUS grading system adapted from radiology incorporating the ecotexture of the pancreas relative to the spleen, as well as the ability to visualize the main pancreatic duct with salt and pepper dots in the parenchyma has been suggested to assess fatty pancreas. With disadvantages طبعا انها invasive procedure with risk factors of complications and need of sedation. The MRI probably the test of choice, even though not the most sensitive, but it's quite available. And what made it the test of choice is the availability and the relatively non-invasive nature, safe. It can be used in children, and also a high sensitivity. And then comes the proton magnetic resonance spectroscopy, which is, I think, going to be the test of choice to diagnose pancreatic steatosis. So how does this affect us as clinicians? Clinical significance of pancreatic steatosis, is it causing so much problems? Well, yes, some factors and some diseases have been studied and linked to pancreatic steatosis, although in many cases still we don't know if it is a cause or a result. But development of diabetes mellitus was quite notable. Pancreatic islet cells fat infiltration leads to reduced insulin secretion and increases development of type 2 diabetes. And the presence of more than 25% of pancreatic fatty infiltration is associated with significantly increased risks of development of type 2 diabetes mellitus and generalized atherosclerosis. Also pancreatitis. Risk factors for pancreatic steatosis such as obesity and components of metabolic syndrome are also the same risk factors for acute pancreatitis. So they share common causes and common risk factors. However, when acute pancreatitis due to any etiology affects a fatty pancreas, it is usually more severe in intensity and is a significant risk for developing subclinical chronic pancreatitis. With acute pancreatitis in patients with pancreatic steatosis, there is more organ failure, more local complications, prolonged hospitalization, and increased mortality. How about the pancreatic enzyme levels? We would expect that they could be الguide والمؤشر بتاعنا. On the contrary, studies are even controversial. Few studies showed that serum amylase value is actually significantly lower in patients with fatty pancreas compared to normal pancreas. Other studies indicate that there is no association whatsoever between fatty pancreas and the serum amylase or lipase concentrations. And the Gallows syndrome, which is the benign pancreatic hyperinsulinemia, has not been linked to fatty pancreas in many studies, so there is no relationship. Pancreatic adenocarcinoma is very notable with fatty pancreas. Fatty pancreas is independently associated with an increased risk of development of pancreatic carcinoma. Patients with increased pancreatic fat have a poor outcome than those who develop cancer in a pancreas without steatosis. Chronic inflammation with with excessive fat accumulation might be the cause of cell injury and development of pancreatic carcinoma. So this is the only causal parameter that can be linked to pancreatic carcinoma. Pathophysiology of development of pancreatic cancer in non-alcoholic fatty pancreas disease is similar to how NAFLD causes liver cancer. Pancreatic exocrine insufficiency, this is also a clear relationship with pancreatic steatosis, and pancreatic steatosis can actually lead to exocrine pancreatic insufficiency by fat droplet accumulation in the pancreatic acinar cells and consequent lipotoxicity, destruction of acinar cells by both inflammation and fatty replacement, and negative paracrine effect of adipocytes. Post-operative pancreatic fistula, development of a pancreatic fistula is significantly increased after pancreatic surgery in patients with pancreatic steatosis and have a 10 times higher risk of incidence of fistula formation in pancreas than those with fibrotic pancreas. Carotid atherosclerosis could be a marker of higher risk of cardiovascular disease, especially in non-obese individuals. Cardiovascular risk prevalence with non-alcoholic fatty pancreas disease on ultrasonography is associated with increased aortic intima media thickness and epicardial adipose tissue. Therefore, it could also be a marker of higher risk of cardiovascular disease. Whenever you find pancreatic steatosis, please take some time to look at the cardiovascular risks. And of course, there is a clear correlation between NAFLD and non-alcoholic fatty pancreatic disease, with 70% of patients of NAFLD will develop NAPLD at a certain point in time, and normal liver, in 97% of those with normal livers, they will have no fatty pancreas. Differential diagnosis, only two items we have to differentiate: the dorsal pancreatic agenesis and the lipomatous pseudo hypertrophy, and those can be ruled out very accurately with EUS and MRI. Management, there is no treatment. You have to take all action to try to prevent the disease before it's happening, dealing with metabolic syndrome, obesity, diabetes mellitus, and of course increased physical activity has been linked with less burden of fatty pancreas. And my message is we may be opening the box of Pandora, so we have to be careful. Thank you.
شكرا دكتور حسام. في أي أسئلة؟ اتفضل دكتور خالد.
Dr. Hossam, thank you very much. Dr. Ghoneim, thank you very much for your presentations. أنا انتظرت لما أسمع البرزنتيشن بتاع حضرتك بعد الدكتور زين، لأن هو السؤال موجه لحضراتكم أنتوا الاثنين. العيان المصري سهل جدا يعيد الالتراسونوجرافي من نفسه، سهل جدا يعيد السي تي من نفسه تاني زي ما بنشوفها في الفاتي ليفر. هو بيبقى عنده تصور انه انا عندي هيباتوميجالي، انا عندي فاتي ليفر، طب الدهون دي هتروح. افهم ان الترايجليسيرايد انديوست اكيوت بانكرياتايتس كود بي كنترولد باي ميديكال تريتمنت. السؤال بقى اللي موجه لحضراتكم، الفاتي بانكرياس وات ايفر ذا كوز زي ما حضرتك عرضت، از ات كنترولبل اور ريفرسبل؟ العيان هيرجع تاني بعد ما اتحسن، هيعمل سونار يقول لك الدهون لسه موجوده على البنكرياس. فردي عليه ابلايد وايز هتفضل كده ونحاول نمنع البنكرياتايتس، نحاول نمنع الكومبليكيشن، ولا it is reversible if we avoid the risk factors if you decrease your body weight؟ لان العيان هيفضل يزن بالموضوع ده. راي حضرتك؟
هجاوب حضرتك من الليترشر about the fatty pancreas. ما شفتش حاجه في الليترشر بتقول ان it's reversible. كله بيتكلم على trying to avoid development of fatty pancreas, recognizing early signs of metabolic syndrome و dealing with it before it can cause a disease. الحاجة التانية برضه حضرتك we still don't know for sure are we dealing with a disease or a finding. يعني shall we treat fatty pancreas ونقعد كل شوية نبص على الايكوجينيسيتي وكده بيتحسن ولا لا، او نبص على الانزيمز هو كده بيتحسن ولا لا؟ ما فيش جايد لاينز تقول كده.
دكتور زين it's the same for the hypertriglyceridemia. يعني what had been infiltrated the pancreas will be.
I can maintain الليفل بتاع الترايجليسرايدز اقل من 500 بالدراج ثيرابي. ليه؟ لان العيان ممكن يتعرض لانذر اتاك في اكوت بانكرياتايتس، انذر اتاك في اكوت بانكرياتايتس. فانا المهم بالنسبه لي ان العيان ده مانتيند على دراج ثيرابي للليفل اقل من 500
to avoid البانكرياتايتس. لكن زي ما قال الدكتور حسام انه الفاتي انفلتريشن that occurred already will persist.
اوكي
ثانك يو فيري ماتش.
طيب شكرا جزيلا.